Honestly, originally I didn't know that Stridor was going to be like, I thought it was just going to be a topic review is going to be in the email, so like everybody knows this sort of Stridor. So, but I was going to have this and then just going to have you guys identify it, but obviously you already know what it is. But just so that's what Stridor sounds like. Does anybody know which kind of Stridor this is?
It's Croup.
So yeah, I appreciate more of an inspiratory, but it also sounded like a little bit of expiratory as well. So, but my lecture is going to be over Stridor whenever I'm working in the ER, but Stridor. Sometimes it might be like this because it can be an airway emergency. So I think it's important that we kind of know, what's going on. And so, with this lecture, it's talking about Stridor in infants and children. So just, a little bit, it's going to be a little bit vague, and because there's numerous causes of Stridor, and honestly, some of these subjects on Stridor are their own lecture within themselves. So just know that some of this stuff may be a little vague, but I'm going to kind of go into some treatments. And the biggest thing I want you guys to take out of this is identifying, Stridor and kind of having a differential in your mind. So that's kind of the biggest goal of this presentation. I'd like to thank Dr. Feeks, Raul, and Fletcher. Kind of sidebarred them in the ER yesterday about this. So Stridor is basically a high-pitched, harsh sound from turbulent airflow. And so it's a little bit different from wheezing, because wheezing, it could be, you have different sounds, but Stridor is actually monophasic, and it's kind of from a narrowing in a certain point in the airway, versus like wheezing, which could be from like, coming throughout the airway. So you get usually just a monophasic sound, and small inflammatory changes can result in an airway obstruction in kids. So even as small as like 1 millimeter decrease in diameter can cause Stridor in kids. So I don't know if you guys kind of know the effect of Stridor. It's like a Venturi effect. Basically, it's like you have this narrowing, and then after that, you have a decrease in the pressure. And so this decrease in pressure causes vibration on the walls of the airway, and that's kind of how you get that Stridor sound. So with Stridor, your differential is kind of going to depend on your age. This is a symptom, it's not a diagnosis. And the history and exam are important. So within the history, kind of want to know like some key things. So first thing, it will be the age. So in neonates, this will kind of give you a different differential. So neonates and infants will probably be more like congenital disorders. So it'd be like laryngeal malacia, subglottic stenosis, tracheal malacia, and things maybe like a subglottic hemangioma. And with infants and toddlers, it's mostly going to be Croup. School-age children, you're probably going to see maybe like a PTA or vocal cord dysfunction, which vocal cord dysfunction can typically present with like numerous episodes of Stridor. For all other ages, you can think about anaphylaxis and also bacterial tracheitis. So, and with the other parts of the history, you kind of want to know the acuity of the onset. So if it's more acute in onset, you're going to think maybe infectious etiology, or we're talking about kids, so foreign body can also be within your differential. And if you have chronic or those kinds of symptoms, it could be like subglottic stenosis. Maybe the kid was intubated or something like that. So another thing that's important is also to get associated symptoms. So an important one would be like a fever. So if they have a fever, you may be more inclined to think this might be an infectious cause. Or if they have a mental status change, that could also, anxiety. Anxiety you typically see in like an epiglottitis. Drooling, cough, voice tone, a muffled voice can show you that it's probably supraglottic versus a like hoarse voice, which could be in the glottic area. Also, like things like hives, and like you may have onset during sleep. So as far as the initial management, just because we are talking about respiratory disorders, you kind of just want to make sure this isn't an emergent airway. If it is an emergent airway, I'm not going to get in depth about it. But these are some of the things we want to look out for. It'd be like tripoding or the sniffing position, severe respiratory distress, cyanosis, or if they're like unable to speak or cough. And so with the emergent airway, you either want to try to intubate. If you can't intubate, then you may have to do a jet insufflation or a needle Croup. If they're less than 8 years old, if they're greater than 8, then maybe consider surgical airway. So this is explaining kind of the mechanism behind a extrathoracic cause of stridor. So with the extrathoracic cause of stridor, you're going to get more of an inspiratory type of stridor. So basically, when you have expiration, you're kind of going to push the air out of your lungs, and because the area of narrowing it's going to kind of push out the airway, so it'll make the airway more open, so you won't hear it as much. However, when you're breathing in, you're kind of trying to suck in the air, and so that's going to cause a collapse because the pressure outside, like the atmospheric pressure, is going to be a little bit more than what you're creating in your airway, so that's going to basically make the airway collapse a little bit, and then you'll hear stridor. So does everybody get that? Good. Okay. And essentially, the complete opposite happens with intrathoracic cause of stridor. So this is just kind of going over the anatomy and places where you would see causes of stridor. So above right here, I'm circling with the mouse, that's a supraglottic area. So typically these areas, you're going to have inspiratory stridor. And so that can kind of help you differentiate where you want to go with your diagnosis. Same thing with the glottic and subglottic area. It's saying more inspiratory stridor, but you can have sometimes inspiratory and expiratory, so it could be a biphasic stridor. And this is because the structures, around your vocal cords are a little more rigid. And also sometimes it may be a fixed lesion that really doesn't collapse or expand with breathing. So that's why you can get like a biphasic type of stridor. And then intrathoracic would be below, kind of in the trachea. And other causes could be infection, foreign body, like anaphylaxis, or you can have some congenital causes as well. So I think for all intents and purposes, I would probably just break it down by age. That's kind of how they did it in anomalies. And so basically less than 6 months, you'll see more of your congenital anomalies. And greater than 6 months, you'll kind of see some acquired causes of stridor. So first we'll talk about the less than 6 months. First one is laryngeal malacia. So essentially this is from a developmentally weak larynx, and basically it's just kind of like a floppy larynx. So you'll get more of an inspiratory stridor, and it presents shortly after birth, and it can worsen with respiratory infections, or sometimes it can worsen when the baby's sleeping or feeding or kind of relaxed. An important thing to note is that with this, they're usually better in prone position. It typically resolves by 18 months of age, and it's usually diagnosed with fiber optic laryngoscopy. So just like to show a video of it. You see how floppy it is. I don't know, there's no volume, but it seems like with the inspiration it's collapsing a little bit, and this can be the cause of strength. Next one is tracheal malacia. So this comes from an intrinsic defect in the cartilage. So basically it just means it's a little more soft, and most of the time it's congenital and they're intrathoracic. So sometimes they can be caused by another congenital anomaly, like a vascular sling, or maybe some mass effect pushing on the trachea. They usually resolve by 6 to 12 months if it's purely just a defect in the cartilage, and it's usually diagnosed with a bronchoscopy. Typically these congenital ones usually get worse with like an upper respiratory infection. So, if there seem to be in some respiratory distress, at least for tracheal malacia, you can try CPAP to increase pressure in the airway and kind of open it up. Next one we're going to talk about is vocal cord paralysis. So this can be congenital or acquired. Usually most of the time it is congenital, acquired, and it's usually unilateral or bilateral. The way it's usually acquired could be, they could be a neonate and they could have been intubated, or they could have had a surgery, and you could have like a thyroid surgery, or like fixing a tracheoesophageal fistula, and sometimes you can hit the recurrent laryngeal nerve, and so that can cause a complete paralysis. With unilateral paralysis, they're different than bilateral because you have stridor, you have a hoarse voice, and you have cry changes. With bilateral, you may have a normal voice within the kiddo, and they may have a normal cry, but they can present with stridor and respiratory insufficiency. And it's, honestly, this one is a little bit more bilateral, is usually after 6 months, just because with respiratory demand, sometimes they might be walking, or they're growing, so they have more airflow going through. So this actually can present after 6 months. And the way it's diagnosed is through flexible laryngoscopy. The next one is subglottic stenosis, and so this one can be acquired or congenital as well. It typically is more acquired than it is congenital. It's usually acquired through a prolonged intubation. So say you have like a preemie baby or ex-preemie, and they were just intubated for a while in the NICU, and then this could be a result of that. So it's usually found within the first few months of life, and it's about 2 to 3 millimeters below the glottis. And this one would be diagnosed as well with the laryngoscopy. And a lot of these congenital problems, you'll probably go to ENT about it. Consult ENT. ENT can fix it, usually through some type of surgical method. Next one is a subglottic hemangioma. So these typically enlarge throughout the first year of life. Just like the hemangiomas on kids that are cutaneous, they usually regress by 5 years. And you want to examine the skin thoroughly for that. The thing about these is that these can actually be an airway emergency because the hemangioma can continue to grow before it regresses. So it can actually just completely occlude the airway. So they're diagnosed with a laryngoscopy, and just as an example, this is how severe it can get compared to a normal airway. If you do in fact are able to see one of these in the ER. Next one is the vascular ring and sling, and most of these are asymptomatic, about 74%. They're usually intrathoracic. There are other variants of this. I didn't get too much into details into it, but this is just one of the variants where it's a double arch. But some you can have a right aortic arch where it also impinges on the trachea. These may get worse as the child grows, just because the airway does get larger and the patient may just have an increased oxygen demand. The chest X-ray, I couldn't find a good one, but they may reveal subtle narrowing and anterior compression of the trachea. So typically you may see these on a lateral X-ray. Not really so much for us, but these are investigated with a bronchoscopy, a CT angio, which, if the stridor is concerning and they're respiratory distress enough, and if you think about it, and this is on your differential, you actually may get CT angio in the ER, and they'll also use echo. These are usually associated with other congenital anomalies like tetralogy of Fallot. So if they, again, this is why history is so important, because if they have congenital anomalies and they have a history of stridor, this is just this is just something you have to think about. The last congenital one is going to be laryngeal wets. This is a failure of absorption of the epithelial layer. They're in complete separation of the vocal folds. So usually these will present in respiratory distress, or they'll have an unusual cry during infancy. You'll see these on laryngoscopy. Sorry, I can't say it. ENT would usually fix these. Sometimes they can just do a lysis of it. Sometimes they use fancy stuff like a CO2 laser. So, and next we're going to talk about stridor and greater than 6 months old. So I think this is the most common cause of stridor that you see in kiddos is viral croup. This is purely a clinical diagnosis. It is typically caused by the parainfluenza virus, but you can have other viruses cause it. RSV can cause it, enterovirus can cause it, human metapneumovirus can cause it. You're usually about 6 months to 3 years of age, and they usually peak at 1 to 2 years. So again, this is why age is important when coming up with your differential for Stridor. The classic question, or as far as like fourth view goes, they'll be described with seal-like bark cough. So I got mixed information. Like Tip Nally said severe over the 3rd and 4th days, but then I went to Up to Date and said it's usually severe in like the first 1 to 2 days. So, but either way, you're going to have URI symptoms, and it could last up to a week. On the soft tissue of the neck, you can see a steeple sign. But this is not technically diagnostic. Again, it's going to be a clinical diagnostic. You got to get the history of the patient and just kind of characterize the Stridor as well. And this is classic steeple sign you'll see. So you can assess the severity. I'll go over the severity in a little bit, but treatment depends on the severity. But all in all, you want to do corticosteroids for all patients. Typically in the ER, we do dexamethasone. If it's moderate to severe Croup, you can use nebulized epinephrine. And this only lasts 2 hours. So if you're going down an epinephrine route for these patients, you got to make sure you observe them for at least a minimum of 3 hours, because the epinephrine can wear off and then they can have a relapse of Croup. So this is very important to know. Read that beta-2 agonists are not recommended in these patients, basically because you don't have any smooth muscle in the larynx, and that's kind of where the inflammation is. And so with the beta agonists, it can essentially just worsen the edema and cause more swelling. So typically we give beta agonists to these patients. This is called the Wesley score, and this is basically for the Croup severity. Where all these blanks are, you're not gonna, for instance, like cyanosis, it's either none, or it's a score 4 with agitation, or 5 at I would just go to like MD-Cal, and put it in, or if it's on your phone, to calculate the score. Basically, again, like the higher the number, the worse the severity. So with mild, you can basically do dexamethasone and essentially discharge them. With moderate to severe, you will probably want to get into racemic epinephrine. And you typically go either way with these patients, admit or discharge, which kind of just depends on how they are in your reassessment. And then impending respiratory failure, essentially you're just going to want to intubate these kids. As far as the disposition, essentially you're just going to admit there's no improvement. They have tachypnea, retractions, they're not tolerating PO intake, and they have hypoxia. As far as discharge goes, you make sure they're non-toxic appearing, they're able to drink fluids. Again, like I was saying, it's been 3 hours since their last epinephrine nebulizer, and you give good discharge precautions. So with these discharge precautions, you kind of want to advise them if they have like tachypnea, they have drooling, they're not tolerating PO, they have like cyanosis, just respiratory distress. These are the good discharge instructions you want to give to the parents to bring them back to the ER immediately. Next one is epiglottitis. Typically you see these in 1 to 7-year-old kids. It's an acute inflammatory condition. It used to see it a lot more prior to the vaccination era. So nowadays, there are a couple case reports of H. influenza still causing epiglottitis, but it's typically going to be other bacteria. This is very abrupt. You're going to have fever, you're going to have drooling, sore throat. The kid's going to look anxious. They're going to be in a tripoding position. They're going to be in a sniffing position just to try to get as comfortable as possible for breathing. You don't actually need the lateral neck x-ray if you have a classic presentation of epiglottitis. The important thing is this can be an airway emergency. So this is how bad the epiglottitis can get, and this is why it's an airway emergency, because you get all this edema of the airway, and it can cause an obstruction. If y'all see the thumb sign, it's right there. And this is the epiglottis on the lower neck X-ray. So you want to give nebulized racemic epi, get ENT, consult stat, and probably anesthesia on board. If you're going to, if you notice this patient probably should be intubated in a controlled setting in the OR. Unless they're having respiratory failure, you know, in the ED, then you may want to go surgical with the airway. But if, you know, if they can tolerate it and they're not in too much distress, then you know, get everybody else and mobilize them. And then you also want to give antibiotics, second or third generation cephalosporin, and empirical vancomycin. Bacterial tracheitis is about 3 months to 13 years old with a mean age of 5 to 8 years. It's often secondary to a viral URI, so usually in questions you'll see like they had coughing, had a runny nose, maybe a sore throat, and then all of a sudden they're going to get worse and they're going to get very toxic appearing. This also, like epiglottitis, is an airway emergency. It's most commonly caused by Staph aureus. The antibiotics you want to get on board immediately are ampicillins, sulbactam, and third generation cephalosporin and clindamycin. On the lateral neck X-ray, you might have a subtle finding of like kind of the tracheal margin right here, kind of extending into the trachea. And on a bronchoscopy, this is what you would see with the pseudomembrane. So this is also known as like bacterial Croup as well. Foreign body. So this one is most commonly between 1 to 3 years of age. I think this is about 80% of the ages that you'll see a foreign body in. The most common objects are food and toys. So as far as food goes, like peanuts, grapes, raisins, other small hot dogs I read as well. You want to suspect a foreign body with a history of sudden coughing and choking, but you know, if you suspect a foreign body, it doesn't have to deal with the duration, but this is a typical picture, but sometimes they can have prolonged coughing that just won't go away. So you still need to have in your differential even if it's not as abrupt. The radiographs can be helpful to confirm a foreign body, but they're not always diagnostic because about 75 of the objects are radios, so you may not see them. So you may have to look for other subtle findings on the X-ray. When it's more distal in the airway, a bronchoscopy with the negative X-ray and bronchoscopy can also be used to remove the foreign body as well. So I have a couple X-rays. I do a little bit, but it's most commonly in the right bronchus. Next would be the trachea, and then about 2 to 3% on the larynx. And if it's an emergent airway and you feel like they're very obstructed or in a lot of respiratory distress, you could do direct laryngoscopy and try McCleave forceps, which almost look like alligator forceps, but they're a little bit bigger, to try and remove the object. And then kids will be kids. Sometimes you'll see bilateral foreign objects in each bronchi. So I have this X-ray, and so where do you guys think that this object is lodged just by the lateral X-ray? All right. So where do you think it's at now? So who thinks it's in the trachea? Raise your hand. Who thinks it's in the esophagus? Okay. If everybody thinks it's in the esophagus. Okay. Yeah. There's also another subtle finding. Do y'all see here how the trachea goes right there, and the coin is actually in the kind of outside of the margin of the trachea. So it's actually in the esophagus. So just because coins, typically present as linear in the AP X-ray, they may not always be in the trachea, but this can also potentially cause stridor just because it's pushing on the airway. So it's just something to think about. It's not always like textbook, but like I saw this case report in like a pediatric EM on like ASAP. So, just something to note. This is a earring in the right main bronchus that got stuck. This one is a kid, 18 months old, is playing outside, and then has, abrupt sudden onset of coughing. So you guys know where the foreign object is in this kid.
The left.
So he thinks it's in the left. Who thinks it's in the right? Okay. I'll show a couple more x-rays. Okay. All right, so who again thinks it's still on the left? Okay, what about the right? Okay, I can't unsee it now, but what about now? So this guy's, see right there? So this was a stone stuck in that kid. But some subtle findings you may have is when you're on the lateral decubitus x-rays, you see how it's more, you see how it's more radiopaque here. So when you have a foreign object obstructing the bronchus, you're going to have a hyperinflated lung, and it's going to be more radiopaque. So do you guys notice that subtle difference? So these are types of differences you can note on x-rays. Bilateral decubitus x-rays typically aren't used to detect foreign bodies, but this is one instance where it actually can help you.
Go back to the PA.
So now, yeah, I can't even see it now. It's like
no, but not even the foreign body though. See how the left is hyperinflated?
Oh yeah, no, true.
Right, it's more radiolucent in the lower lung field. So you can do a screening x-ray lung field.
Another cause of stridor could be retropharyngeal abscess. So these are 6 months to 4 years of age. They're actually rare, greater than 4 years of age. And this is because in the retropharyngeal space, you have lymph nodes, but they involute by the time you're typically 5 years old. So they're really not there. But these may evolve insidiously over days. You'll get neck pain, fever, dysphagia, have excessive drooling. You can have a muffled voice because this is super glottic. On an x-ray, you can have bulging of the posterior oropharynx. So you can see these on lateral neck x-rays, but the CT is helpful for the definitive diagnosis, and actually you can define the infection and know how large this abscess really is, because when you consult ENT, they'll actually be able to, some of these can be treated medically if they are small enough, and they don't have to be drained. But this is what you would see. There's the bulging of the pharynx. And then here's an example of what you can see on the CT scan with the large abscess right here. And there's the airway. So airway that narrow can definitely cause some stridor. So with these, you want to do the IV, give antibiotics, call ENT, and they'll be admitted. Most of these are mixed flora with Staph aureus, Strep pyogenes, Strep iridians, gram-negative rods. I didn't mention all the causes of stridor, but one is anaphylaxis. I think we should all know what that is and how it presents. Airway burns can be either thermal or caustic, caused by chemicals. PTA, I feel like we know pretty well here. And then paradoxical vocal cord function, which is kind of like, vocal cord paralysis, but this is just dysfunction of the cord versus total paralysis. So I have a couple of questions here just to kind of reinforce what we had talked about. I'll read the question and then we'll see what the answer is. A 3-year-old male presents with fever, cough, difficulty breathing, times 1 day. Mother reports that the patient has had 4 days of mild cough, sore throat, and rhinorrhea, and today the patient suddenly appeared much sicker. They're up to date on immunizations. Vital signs are heart rate 145, respiration rate 30, tempo of 39.6 Celsius, and setting at 96% on Romero. The patient is ill appearing, lungs are clear, but there's inspiratory and expiratory stridor. You give nebulized saline, racemic epi, steroids, and the patient is not improved. A soft tissue radiograph shows minimal symptomatic narrowing. So which of the following is the most likely diagnosis? So how many people think this is croup? How many people think this is epiglottitis? bacterial tracheitis and foreign body aspiration. All right, so yeah, this is bacterial tracheitis. So like I was saying earlier, you have that classic prodrome with like having a URI and then all of a sudden like, the kid looks sick. And then you also see the subglottic narrowing that demonstrated on the x-ray previously. All right, next question. A 7-year-old boy presents to the ED with fever, a muffled voice, and difficulty swallowing. On physical exam, he's stridulous and in obvious respiratory distress. His BP is 110/70, heart rate 130, he's breathing at 38 breaths per minute, and he's very febrile 103.2. Which of the following is the most likely diagnosis? So how many think it's an RPA? Okay, Epiglottitis. All right, bacterial tracheitis and Croup. So nope. This one is Epiglottitis. So again, the two answers I was between was retropharyngeal abscess and epiglottitis, but the kid is 7. So again, the retropharyngeal lymph nodes should have been diluted by now. So if it was less than 4-year-old kid, this could have potentially been a retropharyngeal abscess given the limited information we have here. But since the kid is 7 years old, it's more likely epiglottitis. All right, last question. A 6-year-old boy presents to the ED with fever and respiratory distress. On physical exam, he's toxic, stridulous with accessory muscle use, and has intercostal retractions. You are concerned about respiratory fatigue and impending airway collapse. Lateral neck x-ray reveals an enlarged epiglottis. Which of the following is the most appropriate next step in management? So are you going to crank in the ER? Who's going to do that? Nobody. What about a crank in the OR by ET? He's going to intubate in the ER. And then intubation in the ER by anesthesia with ENT outside for surgical airway. So again, it's deep. So my lecture, does anybody have any questions? Yes, Dr. Sure.
I just want to emphasize that epiglottitis has become more of an adult disease. Although if someone hasn't been immunized, you might see it in young children. But in adults, it presents a little bit differently. So it usually presents with a terrible sore throat early on. And when you look in the throat, expect to see maybe a peritonsillar abscess or a terrible strep. You don't see that much, but they have, a lot of pain, and they also may have some drooling and trouble with their secretions. And then when you do your x-ray, usually they're not in stridor yet because they have bigger airways. And then if you do your x-ray, you'll see the thumb sign. And if you're still not sure, you can get ENT, come down and do the nasopharyngeal exam, and confirm the diagnosis. The only other thing I wanted to say that with bacterial tracheitis, because staph is the most common, and nowadays staph has changed, and they're so sick with that I would actually use Bengal there along with something else. But that's where I would add Bengal whenever you're afraid of a very bad staph infection. So there I would use Bengal over Unicid alone. I probably subtract some Bengal.
Dr. Ellis?
Yeah, I just had one other cause of stridor that I had. It was bizarre case in St. Louis. It didn't have stridor per se, but had persistent crucial cough that wasn't associated with infection or anything else. And he got steroids, albuterol, antibiotics, chest x-rays for the past couple of months. But I did like 2 different neck x-rays on him. He had an apical lung aneurysm that only when he exhaled would pop out and push on his airway.
Oh, wow.
So you'll never see it, but that's why the neck x-ray initially was normal. And there was radiology said, I couldn't tell it to send him back. He happened to be exhaling on the second one. But that would be another, more congenital in a young kid, external compression.
All right. No other comments, questions, concerns? Okay, before we wrap up, there's a couple of. Oh, sorry.
So, just in general, like less than 6 months, you're typically going to have a congenital cause, greater than 6 months, with relatively short duration is typically an acquired cause. So just remember the characteristic of stridor gives you a lot of information, typically about the location of where the stridor is coming from. Histories in these kids are very important because they can, some of these diagnoses are purely clinical. So hopefully you guys get a better general idea of stridor and where to go with your differentials from here on out.